Throughout all these lectures on hematology, we have been discussing anemias. We started off by defining anemias, and then through a series of lectures, we discussed the various types of anemias, starting off with the normocytic anemias, then moving on to the microcytic anemias, then we moved on to the macrocytic anemias. Now, in the last two lectures, we discussed about the hemolytic anemias. In the previous lecture, we were majorly concerned about the inherited types of hemolytic anemias, and today's lecture is about the hemolytic anemias which are acquired. So these are basically any problems that lead to the hemolysis of the red blood cells, which is acquired by the RBCs over a course of their lifespan. This is not an inherited disorder. Acquired hemolytic anemias can have a similar presentation as compared to the inherited hemolytic anemias, but acquired hemolytic anemias can present later in life as compared to the inherited hemolytic anemias. Now let's start off by classifying these acquired types of hemolytic anemias. The acquired disorder can either be because of a mechanical destruction of red blood cells. Anything in the bloodstream that mechanically destroys the RBCs can lead to a hemolytic anemia. Similarly, certain types of infections, which we are going to talk about in detail, they can also cause hemolysis of the RBCs, leading to the anemias. Then there are certain immunological processes which interfere with the RBC's normal functioning and structure, and that lead to hemolysis of the RBCs. Specifically, there can be an autoimmune process occurring on its own, or it can be secondary to another autoimmune disorder. Then there is a condition called paroxysmal cold hemoglobinuria, which is a rare condition, but especially this condition targets the children, and certain antibodies are present here that can lead to hemolysis. And then there is another related disease called the cold agglutinin disease, in which certain types of antibodies under cold temperatures affect the RBCs and lead to their destruction. Moving on, certain types of toxic agents and drugs can also cause hemolytic anemias. And finally, we're going to discuss a condition called paroxysmal nocturnal hemoglobinuria, which is a very important condition, and it is very important to understand the pathophysiology of this disorder. So these are going to be the main talking points of today's lecture. Let's start off by discussing about the mechanical destruction of cells. Now, as the statement indicates, there is a mechanical destruction of certain types of RBCs. This type of destruction can be related to three types of things. And on the peripheral blood smear, we're going to see certain types of RBCs shape and presentation, as it is evident in this slide. As you are seeing, there are some normal RBCs, and in between these normal RBCs are these small spherical shaped RBCs, in which you can see that they have two pointed ends and a normal elliptical body. This is called generally a helmet cell or a schistocyte. Schisto means something which is broken. So because of some mechanical problems, which we are going to talk about in a minute, the RBCs get fragmented or broken into these types of small pieces. There are various shapes, certain like this. This is the classical helmet cell. These are termed as schistocytes, means broken RBCs or fragmented RBCs, or the helmet cells. Like here, you can see certain types like this. So these RBCs have passed through certain types of blood vessels or through certain walls, which has led to their fragmentation or destruction, as compared to these normal RBCs, as you are seeing in the other peripheral blood film. Now, this mechanical destruction can either be a microangiopathic hemolytic anemia. Microangiopathic means that the RBCs are broken when they're passing through the small blood vessels. This happens when there is certain types of coagulation problems that lead to fibrin deposition in the smaller blood vessels. And when these smaller blood vessels have a thrombus or a fibrin deposition over them, then when the RBCs pass through these smaller blood vessels, there is not enough space for the RBCs to move and mold around. So certain parts of RBCs are being chipped off continuously as they repeatedly pass through these smaller blood vessels. This can happen in certain conditions like the disseminated intravascular coagulation or hemolytic uremic syndrome, in which there are fibrin deposition or platelet deposition into the smaller blood vessels, or the microangiopathy. So over a period of time, when the RBCs continue to move through these smaller blood vessels, small part of their membrane gets chipped off repeatedly, and that eventually leads to the formation of these type of cells called the schistocytes or fragmented cells. Now, these schistocytes or fragmented cells can undergo intravascular hemolysis, leading to the anemia and also leading to the certain types of all the manifestations of intravascular hemolysis, as we talked about in the previous lectures, like the hemoglobinuria, the hemoglobinuria, the jaundice, or the hemosideruria. Another condition that can lead to mechanical destruction of RBCs is termed as March hemoglobinuria. Now, this generally happens in someone who has run a marathon or a marathon race or a marathon march and has not adequately rehydrated himself. Then, because of that long-term movement, the RBCs can get mechanically destroyed. This occurs on a very smaller scale, and the patient might even not notice anemia, but in certain conditions or in certain prone individuals who are already have a low hemoglobin count, this March hemoglobinuria can present as an anemia, and so that's why it is included under the terminology of mechanical destruction. Similar to microangiopathic, which occurs in a smaller blood vessels, there is also a condition which we termed as macroangiopathic hemolytic anemia. Macro means big. So this hemolysis basically occurs while passing through the bigger areas, specifically while passing through the heart. If someone has a prosthetic valve, for example, a prosthetic aortic valve, or for example, if someone has aortic stenosis in which the valvular area is very less and there is not enough space for the blood to pass. So the RBCs, while passing through these smaller spaces because of either calcific aortic valves or because of a prosthetic aortic valve, they undergo shearing or tearing, wear and tear over a period of time. So over a period of days, months, or years, the RBCs can get fragmented, and we might have a similar picture to that presenting in the form of schistocytes or helmet cells. So these patients, after the schistocytes are present, they are not able to carry out the normal functioning. So these might disrupt either most commonly via intravascular hemolysis. These are destroyed, and that leads to hemolytic anemia, while they might also get entrapped in spleen, leading to extravascular hemolysis. But that percentage of extravascular hemolysis is generally low in mechanical destruction or macroangiopathic hemolytic anemia. Majorly, the destruction will be because of the intravascular hemolysis. So these three are the major conditions that are concerned with the mechanical destruction. On a smear, how do we differentiate? On macroangiopathic anemia, we're going to see the helmet cells, just like I told about the schistocytes or helmet cells. For the March hemoglobinuria, we have to take a targeted history of the patient that he has recently been involved in a marathon race or a march. And similarly, in macroangiopathic anemia, we're also going to see schistocytes on the peripheral blood film. Now, there are certain types of infections that target the RBCs, leading to their hemolysis. By far, the most common cause in the endemic areas specifically and throughout the history, the infection which has led to hemolysis has been malaria. Because we all know that the malarial parasite targets the RBCs, and it lives inside the RBCs. And when these malarial parasites get their maturity inside the RBCs, they burst the RBC, leading to the hemolysis episode and also the fevers. This is especially endemic in the African part of the world, and it has been a major killer over a period of centuries. But now, with the advent of more advanced medications, this has led to the control of malarial disease. In other parts of the world, the sugar toxin, which is an infection which is caused by the species of E. coli, Escherichia coli, specifically the O157H7 strain, which releases the sugar toxin. This also targets the RBCs, leading to hemolytic anemia. Similarly, there is a specific toxin with the lecithinase activity, which is being produced by Clostridium perfringens species. This Clostridium perfringens, apart from causing other diseases, it also causes very abruptly and very acute hemolytic anemia because of this toxin with lecithinase activity. And this Clostridium perfringens can get into our body either via open wounds, or it can also get the mother can also get infected if she has a septic abortion. So these three major infections, specifically the malaria, the sugar toxin producing E. coli leading to hemolysis, and Clostridium perfringens sepsis, which leads to hemolytic anemias. These are the three major infective causes of acquired hemolytic anemias. As we move on, now let's talk about the immune hemolytic anemias. The immune hemolytic anemia generally occur because of certain immunological processes gone wrong. This can either be because of certain foreign substance entering into the body and the body reacting to that foreign substance, or it can also be an autoimmune process in which the body reacts against its own cells, leading to the hemolysis of the RBCs immunologically. Now let's talk about the mechanism of hemolytic anemias. There can either be a true antibody which is directed against the red cell antigen. Anything which acts as a hapten attaches to the RBCs and induces the formation of an antibody that targets the RBCs. Or it can be any drug or any other substance that acts as a hapten and has an antibody directed against itself. And when that antibody and antigen react with each other, the RBCs can basically become involved as a bystander in that immunological process and lead to the destruction of the RBCs or a hemolysis. So there can either be a targeted antibody directed against the red blood cells, or there can be just involvement of the RBCs as bystanders in a certain immunological process or antigen-antibody complex formation. Overall, in both of these mechanisms lead to immunological destruction of the RBCs, leading to hemolytic anemia. The immune hemolytic anemias can be broadly classified into two major types. One is the cold immune hemolytic anemia, and the other one is the warm immune hemolytic anemia. Now, these two are basically differentiated on the basis of number one, as the name signifies, the temperature at which the hemolysis occurs. In cold immune hemolytic anemias, the RBCs are basically destroyed at lower temperatures or in certain parts of the body, for example, at where the body temperature is generally low, for example, in the digits of the fingers and the toes. While on the other side, in the warm immune hemolytic anemia, there is generally destruction of the RBCs at body temperature or at certain higher temperatures. The antibodies involved in the cold immune hemolytic anemia is generally the IgM, and in the warm immune hemolytic anemia, IgG is the basic antibody involved. So, as IgM can cause destruction either because of tagging of the RBCs leading to the extravascular hemolysis, or IgM can also induce the complement activation leading to the destruction. So in the cold immune hemolytic anemias, we will have both the pictures, the intravascular hemolysis because of the complement activation and the extravascular hemolysis because of the spleen involvement. While in the warm immune hemolytic anemias, because the IgG cannot induce complement, the major pathway or the major route of hemolysis is the extravascular hemolysis in the spleen primarily. Now let's talk about the mechanism, how the immune hemolytic anemias occur, or how the RBCs are going to be destroyed. As you can see here, we have an RBC which basically has an antibody directed against itself, either on its own or it gets entrapped in a mechanical process. This RBC antibody complex, if it is IgM, it can activate complement. This complement activation will lead to the formation of membrane attack complex, and that can lead to the destruction of the RBCs inside the blood plasma and lead to the intravascular hemolysis, leading to hemoglobinuria or hemoglobinuria. On the other hand, these antibodies have their FC chain at their end, and this can be recognized by the FC receptors specifically present on the splenic macrophages. This primarily occurs when there is an IgG antibody involved. So this is the primary mechanism which is present in the warm immune hemolytic anemias. These mononuclear phagocytic cells, which are part of the reticuloendothelial system and are primarily present in the spleen, liver, and lymph nodes, they target the antibody by combining the FC part of the antibody with the FC receptors present on the macrophages. And afterwards, this can lead to either three outcomes. Either the RBC antibody complex is phagocytosed or internalized and as phagocytosed or broken down, or it can get fragmented and the RBC species are chipped off, or we have a process which is called antibody dependent cytotoxicity, which lead to the destruction of the RBCs. This was a major mechanism by which the RBCs are being broken down, specifically intravascularly and in the extravascular hemolysis. What are the signs and symptoms with which a patient with an autoimmune hemolytic anemia present to us? These patients have a very low hemoglobin count. The anemia can be brisk or it can be chronic over a very long period of time. But generally, if it occurs on a shorter period of time or it is acute, the hemoglobin level can be as low as 4 grams per deciliter. So the patient will have profound anemia. Along with that, because of the RBCs breaking down and the hemoglobin being released, the patient will have jaundice because of increase in the unconjugated bilirubin level. The spleen will be enlarged because the spleen will be overworking, leading to the removal of these antibody RBCs complex, and this hypersplenism leads to enlargement of the spleen because of enlargement of the splenic macrophages. And all the signs and symptoms which are present in intravascular hemolysis, like the hemoglobinuria, when the hemoglobin level in the blood reaches a certain threshold, it can get filtered into the kidneys, leading to the hemoglobinuria. And over a period of days, the kidney tubules can take up hemoglobin, leading to the formation of hemosiderin, and that hemosiderin can also be present in the urine, leading to hemosideruria after a few weeks of this immune hemolytic episode. And then there is a rare syndrome called the Evans syndrome, which can also be a part of this autoimmune hemolytic process. What happens in this Evans syndrome is someone who is undergoing autoimmune hemolytic anemia, he or she can also undergo autoimmune thrombocytopenia, in which the autoimmunity can also break down the platelets, leading to all the plethora of platelets problem like thrombocytopenia, bleeding, diathesis, or fragility of the vessels. So these are the major signs and symptoms generally with which a person with an autoimmune hemolytic anemia present. Now let's talk about how are we going to diagnose the immune hemolytic anemias. The major test which has been used from a large number of years is the Coombs test or the direct antiglobulin test. This is named after the scientist Coombs who invented this test. And in this Coombs test, what we do is we basically identify the pathogenic mediator of the disease. The pathogenic mediator of the disease are the antibodies in the immune hemolytic anemias. We take the patient's blood sample and then we look for the RBCs on which the antibodies are attached. This is called a direct test or a direct Coombs test because we directly look at the RBCs which have attachment of the antibodies. We might present that blood sample with a fluorescent antibody targeted against the RBC's antibodies, and when this fluorescent antibody and the RBC antibody complex react with each other, this leads to agglutination of the RBCs in that sample. So that is why this is called a direct Coombs test or a direct antiglobulin test. And this is the major test. It is a very sensitive test for immune hemolytic anemias, so much so that a negative Coombs test or a negative direct antiglobulin test essentially rules out the immune hemolytic anemias. Now let's talk about what are the treatment options we have. Since it is an immunological disease, it is very difficult to cure it on its own. We can transfuse the patient with red cells if the hemoglobin goes down a certain threshold, like goes down to 4 or 5 grams per deciliter, in which the patient has pronounced symptoms of anemia. The RBC transfusion, we have to look for the iron overload as well. Then if the anemia is not very severe and if it is not occurring acutely, we have certain medications like the prednisone, the steroids, that can offset the effects of this immunological process. We have also tried rituximab, another anti-immunological drug, and it has shown very good results. So much so that a combination of rituximab and prednisone. Rituximab is a monoclonal antibody, basically against the CD20 cells. So This rituximab and prednisone combination is now the mainstay of treatment generally for immune hemolytic anemias, and it essentially controls the symptoms of the patient over a large period of time and over a large scale. So this has generally replaced the need for using a large number of drugs, like historically the drugs which were used for this immune hemolytic anemias were cyclophosphamide, cyclosporin, azathioprine. These had their own side effects, but these are now generally have been replaced by prednisone and rituximab combination. We can also give IV immunoglobulins, intravenous immunoglobulins to these patients. The mechanism behind this is that we generally give these types of immunoglobulins, and these are the immunoglobulins then generally these are which are taken up by the spleen. So it is not basically curative treatment, but it is generally because the spleen takes up these kind of immunoglobulins and spares the RBCs which are being coated by the immunoglobulins. So this gives a certain period of time to act while we are basically looking for certain curative management or certain strong medication like the prednisone or rituximab. So it is basically a short-time fix, the IVIG. It is not a long-term treatment. Splenectomy can be done in certain patients in which the medicines don't work and the anemia does not resolve. And as we all know that with splenectomy, we have to immunize the patient against the pneumococcus. And then we also have to give them prophylactic penicillin antibiotics to prevent the infections. And finally, in a donor, if we have a matched donor, the hematopoietic stem cell transplantation, this can be curative, but it has not led to very successful results over a period of time, and the patients can again go into the immune hemolytic anemias. So this is basically something under still research and study. So these are the basic treatment options which we have for patients which have the immune hemolytic anemias. Continuing on certain other types of immune hemolytic anemias, the first part dealt with the autoimmune type of hemolytic anemias in which we had the certain types of antibodies. Now we are going to talk about a condition called paroxysmal cold hemoglobinuria. The word basically explains this disease. Paroxysm means there are certain periods. So this disease does not occur continuously. So there are certain relapses or certain short-term periods over this disease occurs. And the cold hemoglobinuria basically indicates that this occurs at lower temperatures or in the part of the body where the temperature is generally cold, for example, in the toes and the digits. This disease generally occurs in children, and it can cause an acute hemolysis or a rapid hemolysis. The mechanism is not very well understood, and there has been documented certain types of antibodies called the Donath-Landsteiner antibodies. The Donath-Landsteiner antibodies, these are basically one types of IgM antibodies directed against the RBCs, and these can get formed after certain viral infection or certain types of immune stimulus, and these can lead to destruction of the RBCs over a short period of time, leading to an acute hemolytic anemia. The treatment is basically symptomatic, and we basically wait for the disease episode to pass through, and these patients recover after a couple of weeks, generally without any need for certain strong immunological medications. Now let's talk about cold agglutinin disease. In cold agglutinin disease, there are IgM antibody formation against the RBCs. This IgM antibody formation can occur on a large scale that this can lead to a monoclonal gammopathy, in which there is a certain type of bone marrow B cells lineage which leads to this IgM production. And this IgM leads to the destruction of the RBCs or the agglutination of the RBCs in cold temperatures generally. This can happen on its own, but it is also related to certain types of other diseases like certain viral infections, certain types of, for example, RSV type, in certain types of other disorders like the mycoplasma pneumonia infection, this IgM antibody can form. Or this can be a part of a disease called the Waldenstrom macroglobulinemia, and abbreviated as WM. In these kind of conditions, there is a large scale production of the IgM antibodies, and this IgM antibodies then reacts with the RBCs over the cold temperature, specifically at 4 or 5 degrees Celsius, and that can lead to hemolytic episodes. Now, this IgM disease can be considered a part of the syndrome of Waldenstrom macroglobulinemia, because this might be the initial presenting complaint of the patient, that the syndrome starts off by the immune hemolytic anemia, and then over a period of time the other symptoms of this disease develop. So the two important take-home points from the cold agglutinin disease are the IgM antibodies. They can lead to, even the production can be so on a larger scale that it can lead to a monoclonal spike on the electrophoresis. And the other thing that this disease might be related to Waldenstrom macroglobulinemia. The treatment options, again, since it is an immunological process, we use the immunosuppressive treatment, the immunosuppressive drugs like the azathioprine, cyclophosphamide. These have been used historically, but recently the monoclonal antibody rituximab has taken off. Has been the main course of treatment for these patients, and it has shown very good results in a large population. So rituximab can be considered at the present time the major drug which is being used to treat this cold agglutinin disease. This concludes our discussion of the immune hemolytic anemias. Now let's talk about certain types of drugs or toxic agents that can cause hemolysis in the patient, leading to hemolytic anemias. This can either be, the drugs can be oxidative or non-oxidative. The oxidative drugs lead to the oxidation of hemoglobin in the RBCs, and the non-oxidative target the RBCs in certain other pathways. These oxidative drugs basically lead to the RBC damage outside the G6PD deficiency. So G6PD deficiency, as we talked about, leads to the oxidation of the hemoglobin and the formation of oxidized hemoglobin, which can be destroyed. But this mechanism of destruction of the RBCs is different from the G6PD G6PD deficiency mechanism. What are the different types of oxidative drugs? Like the hyperbaric oxygen chamber. If the patient is placed in that chamber for a long period of time, that can lead to the destruction of the RBCs. Certain types of nitrate drugs used in cardiology can cause it. Certain chlorates, methylene blue, IV methylene blue, which is basically used to treat methemoglobinuria, can cause this type of hemolysis. And dapsone, an anti-malarial drug or an anti-leprosy drug, which has been used historically, can also lead to the destruction of the RBCs. Cisplatin is an anti-cancer drug. It has also led to the destruction of the RBCs. And certain aromatic cyclic hydrocarbons have also been reported to cause damage to the RBCs. Now let's talk about certain non-oxidative types like the arsine, the stibine, and the copper. These are basically the heavy metals that have been reported to be toxic to the RBCs, leading to the hemolytic anemia. Lead has also been historically reported to be a part of a syndrome leading to hemolytic anemia, and lead destruction of hemolytic anemia leads to the sideroblast formation, as we talked about in the macrocytic anemia lectures. So these are some of the major drugs which I wanted to keep in mind when we talk about the acquired hemolytic anemias. Now let's talk about how the drugs lead to the destruction of the RBCs. There can be two mechanisms. Either the drug itself behaves as a heptan and leads to an antibody production and against the RBC. So the drug is acting as a heptan, and there is an antibody produced against the drug, and in this process of an antigen antibody reaction, the RBCs can get involved and lead to their destruction. So the RBCs can basically get involved as a bystander when this happens. Or there can be a trigger of RBC destruction because the drug which we are taking either acts as has some molecular mimicry with the RBC's lining, and that leads to a trigger for the formation of antibodies against the RBCs. And this RBC antibody generally targets the RBC's antigen and lead to their destruction. So this is a targeted antibody against the RBCs, as compared to the drug acting as a heptan, in which the antigen antibody reaction has RBC's involvement as a bystander. So these are the two basic mechanisms by which the drugs, for example, penicillins or methyl-dopa, which has been used historically for the antihypertensive treatment, these are the drugs which can trigger hemolysis if they are used over a long period of time. Now, in the last part of our lecture, we are going to talk about the paroxysmal nocturnal hemoglobinuria. As the name signifies, paroxysm means there are bouts or there are periods. Nocturnal means this hemoglobinuria, breakdown of the RBCs, occurs at night. So this term, the disease name basically tells us what is going on in this disease. There are there are episodes of hemolysis in these patients which specifically occurs at night time. Now this is a very important disease, and there are certain pathophysiological mechanisms which are very important to understand what is happening in this disease, to understand all the signs and symptoms and the treatment options which we have. What happens is in these patients is that there is episodic hemolysis specifically occurring at night time, and this is because of certain deficiency of certain proteins on their cell membrane, which are called the GPI anchor proteins. If you remember the last lecture on inherited hemolytic anemias, I showed you a diagram of an RBC membrane in which we highlighted different types of proteins like the N-chirin. Then we linked them with the various types of cytoskeletal proteins. There I told you that there are certain types of anchor proteins called the GPI anchor proteins present on the cell membrane of the RBC. And these GPI anchor proteins are very important for anchoring certain extracellular proteins to the membrane. In paroxysmal nocturnal hemoglobinuria, these GPI anchor proteins are absent. And because of the absence of these proteins, certain types of important proteins like the CD55 and the CD59, which basically are protective proteins for the RBCs. These CD55, CD59 proteins, which are anchored by the GPI anchor to the RBC membrane, these prevent the RBCs from destruction against the complement. So these are the anti-complement factors present on the RBCs, because RBCs are surrounded by the complement all the time. And in certain conditions, like for example, acidosis, specifically, we know that when we are sleeping at night, we are basically under a type of respiratory acidosis because we are breathing very shallow. So that acidotic episode or acidotic environment basically stimulates the complement, and if these protective proteins, the CD55 and CD59, are not present on the RBC's membrane, the RBCs are vulnerable to destruction by these complement. So in these patients with PNH or the paroxysmal nocturnal hemoglobinuria, the GPI anchor, that is absent on the cell membrane. So the CD55 and CD59 proteins are not present, and that exposes the RBCs to the complement, leading to their destruction. So there will be an episodic hemolysis specifically at night, and the major symptom with which the patient presents to us is that the patient has gone to the washroom to pass urine, and when the patient passes urine, there is blood in the urine, and that can be very frightening for the patient. This might happen episodically after a few days, or this might happen on a month, that there is a large volume of blood. So the patient gets very frightened, and the patient has no other signs and symptoms. So this is the major presenting complaint in these patients, that these patients present to us very, very frightened that the doctor, I have been passing blood in my urine and I have no other symptoms. So it is very important to investigate the cause and arrive at a differential diagnosis, including your paroxysmal nocturnal hemoglobinuria in your differential diagnosis. There can be venous thrombosis. I'm going to explain why there is venous thrombosis in the coming slide when we are going to explain the pathophysiology. And there is an impaired bone marrow function leading to pancytopenia. There is a certain problem because this GPI protein is basically present. This GPI anchor is basically present on all types of cell lineage, like the RBCs, the platelets, and the white blood cells. So if there is a gross absence of the GPI anchor, all the types of cells are prone to the complement destruction, like thrombocytopenia can occur, leading to bleeding episodes. Then there can be white blood cells destruction leading to infection in these patients. So this impaired bone marrow function generally targets all the cell lineage. The clinical features are thrombocytopenia because the platelets are also targeted. The patient might have hepatomegaly. This might happen because of the venous thrombosis of the hepatic vein or the portal vein. The venous thrombosis generally occurs because when the platelets are being damaged, they release certain procoagulant factors. These procoagulant factors lead to the thrombosis in the venous side of the circulation. So the large veins like the hepatic veins, the portal veins, or the cerebral veins, they can get affected by these platelets procoagulant factors, and this can lead to formation of thrombosis in these veins. And if the thrombus is formed in a hepatic vein, it leads to hepatomegaly, or it can lead to a syndrome called the Budd-Chiari syndrome. Thrombosis because of the procoagulant factors being released. The patient, because of the hepatomegaly, or if the intestinal vessels and intestinal venules or veins are being involved, the patient might have mesenteric ischemia, and he can present with a severe abdominal pain. There will be neutropenia because of the WBC involvement and the hemolysis process. And the Budd-Chiari syndrome, this is because of hepatic or the portal vein thrombosis leading to hepatomegaly. Budd-Chiari syndrome is very specific, and if we have a patient presenting with a venous thrombus in the hepatic vein or a portal vein, becomes very imperative to investigate that patient for the paroxysmal nocturnal hemoglobinuria, because this can be a presenting complaint of this disease. And this hepatomegaly can, over a period of time, be so large that it can lead to liver failure or cirrhosis, and leading to the ascites as well. And these patients with PNH are also prone over a lifetime. They have an increased chance or increased risk of developing certain types of leukemia, specifically the AML or the acute myeloid leukemia. So anyone with a PNH should be screened periodically over a period of years for this acute myeloid leukemia, because they have a general increased risk of development of these types of leukemias. This picture is very interesting, as this shows the color of the changes of the urine samples over a period of hours. So this urine sample might be taken, for example, at the night at 12 a.m. and then at 2 a.m. the patient has this darker urine showing you that there has been hemolysis. Then 1 or 2 hours later, the urine sample turns like this, and again this can go on and like this. So this shows that this is maybe the only type of disease, paroxysmal nocturnal hemoglobinuria, in which over a period of hours the urine color morphology changes because of the episodic hemolysis. When this urine sample was being taken, there is a large degree of hemolysis, then there is a smaller degree of hemolysis, then again the hemolysis might have increased here because of acidic changes, and this clear sample indicates that there was no hemolysis at this time. So serial urine samples should be taken to evaluate the patients in which we have a high suspicion of paroxysmal nocturnal hemoglobinuria. What are the other lab investigations which we are going to see, or the lab findings? There will be anemia. The anemia initially will be normo or macro, leading to the macrocytic anemia if there is a high degree of reticulocytosis, because the reticulocytes are the slightly bigger cells. And over a period of time, if this bleeding is not corrected, and if we have not supplemented the patient, because the patient is losing iron in the blood, the anemia can turn into a microcytic anemia if the iron is not being replaced. The unconjugated bilirubin, because of the breakdown of the RBCs by the complement, increases, leading to the jaundice formation. The LDH will be elevated because of the release of the LDH by the lysed RBCs. And there is erythroid hyperplasia, because the bone marrow tries to compensate for the loss of the various types of RBCs and the other types of blood cells like the WBCs and platelets. And there is dyserythropoietic hyperplasia, because the proportion of the different cells is not uniform. There can be certain large degree of WBCs, certain smaller degree of thrombocytes. So this is basically termed as the dyserythropoietic bone marrow picture. These are the major labs or the findings on the peripheral film which we are going to find in these patients. Now let's talk about how do we diagnose the paroxysmal nocturnal hemoglobinuria. The major screening test is the acidified serum or the acidified Ham test. What happens in this is we basically place the RBCs is an acidified sample in which the pH is low, and because acidosis increases the complement activation, the RBCs are being targeted by the complement. And if there is no CD59 5 or CD59 savior of the RBCs present on the membrane, it leads to the RBCs destruction. This is a screening test, and afterwards we confirm this with the help of a flow cytometry. Flow cytometry is the test in which we basically look at the RBCs for the presence of these antigens or the presence of the GPI anchor proteins. So flow cytometry is the definitive test, and acidified serum test is the screening test for PNH or paroxysmal nocturnal hemoglobinuria. Now let's talk about the pathophysiology in slight more detail with the help of very clean animation. This will help you understand that how the RBCs are being destroyed in this disease. In a normal or a steady state, what happens is, we have a normal RBC. These blue lines which you are seeing, these are the GPI anchor proteins. These GPI anchor proteins are anchoring these CD55 and CD59 proteins on their RBC's membrane. And these are CD55 and CD59 proteins are the ones which are basically stopping the complement cascade. This is the whole complement cascade. It has all the pathways, the alternative, classical, and the lectin pathway leads to the C3 convertase, which activates the C3 converting into C3b and C3a. And further onwards, this leads to the formation of C5b, leading to the formation of MAC or the membrane attack complex, which has C5b to C6, 7, 8, 9 involvement. This membrane attack complex and these types of complement, they target the RBC specifically in acidotic conditions. But because of the presence of these protective molecules on the surface of the RBCs, these CD55, they stop the MAC or the other types of complement from attacking the RBCs. And a normal CD55 positive and a CD59 positive RBC can withstand the hazard of the complement activation. So the RBCs are being protected from destruction. This happens in a normal person, in a normal or a steady state person. Now compare this to someone with paroxysmal nocturnal hemoglobinuria. In these patients, there is no GPI anchor. There is no bluish line as we saw in the previous slide. So there is no anchor for the CD55 or the CD59 protein. So the RBCs are basically bare, and these are exposed to the complement environment. And so the complement cascade, specifically the C3b and the membrane attack complex, they target the RBCs, leading to their destruction. This leads to a MAC-mediated intravascular hemolysis. The RBCs are being broken down inside the blood vessels, leading to the hemoglobinemia or the hemoglobinuria. And that hemoglobinuria generally presents as blood in the urine, specifically at night time, when because of shallow breathing, we have a comparative respiratory acidosis. And the RBCs are generally abnormal because there is no CD55 and CD59, and they will be lying sooner or later by the activated complement. So this is the basic pathophysiology involved under the umbrella of the paroxysmal nocturnal hemoglobinuria. We treat this disease with the help of an antibody called eculizumab. And what happens when we give the patient eculizumab? The same picture, eculizumab is basically an anti-CD5 antibody, anti-complement antibody. Specifically, it targets the C5 complement pathway. So when we give the patient eculizumab, this MAC or the membrane attack complex is generally taken out of the equation because it needs the C5 component to get activated. So there is basically a halt in the complement activation. But the other complements so this membrane attack complex, when it is taken out of the picture, it cannot lyse the RBCs. And it leads to a somewhat improvement in the symptoms of hemolysis and the patient's hemolytic episodes. In 50% of the patient, it can basically lead to a large reduction of the hemolysis episode, and the patient can be said to be almost cured. There is no cure, but almost that they have no episodes over a period of years or so. But in certain prone individuals, because there is a breakdown here in the complement pathway, there is a buildup of the C3 protein, the C3b specifically. And this increase in the C3b protein can lead to the activation of the RBCs and lead to tagging of the RBCs by the C3. And when the C3 is coating the RBCs, the reticular endothelial cell macrophages in the liver and spleen, they target this C3 protein by combining with their receptors and lead to the opsonization or the phagocytosis of these RBCs. So 50% of these patients can generally have no hemolytic episodes, but in certain other 50% of population, the hemolysis can be greatly reduced, but it will still be present. And this will be because of the extravascular hemolysis occurring via spleen in these patients. So this is important to understand that eculizumab can be a very good drug for certain patients, but in certain other types of patients, it can lead to a reduction in the hemolytic episodes, but it cannot be a definitive curative or a definitive management for these patients. So these diagrams very clearly or very nicely explain what is happening in the PNH, is happening when we give the patient eculizumab or the anti-C5 antibody. So with C5 blocked, a PNH cell will be protected from undergoing intravascular hemolysis, but once opsonized by the C3, like here, once it is opsonized by the reticuloendothelial cell macrophages because of the C3 present on the RBCs, it will become a prey to macrophages. So the intravascular hemolysis is generally subsidized. There will be no hemoglobin in the urine. The redness of the hemoglobin of the urine sample at night will be better. But there will be certain other symptoms of anemia because of the extravascular hemolysis. And now let's look at the various treatment options that we have in these patients. Because there is no definitive cure of PNH, as we saw, because the RBC's cell membrane do not have a protein because of which the whole cascade is being activated. So we basically do the symptomatic management. We have to replace the folic acid because to counteract the demands of the body, to supply the enough folic acid for the developing RBCs or for the increased erythropoiesis in the bone marrow. Similarly, if there is a large degree of hemolysis or a large degree of blood loss, we have to replace iron, because if we don't replace the iron over a period of years, the hemolysis, the RBCs can become microcytic and it can turn into an iron deficiency anemia. The humanized monoclonal antibody, the eculizumab, is being tried and has shown very good results, as we saw in the previous slide. Along with that, if there is a large degree of acute hemolysis in certain patients, the blood transfusion can be tried to stabilize the patient. And in this case, it is imperative acutely to stabilize the patient first before going on to the further treatment options before the patient is stabilized. Certain types of immunosuppressive treatment have been tried in the past, certain anti-thymocyte globulin and cyclosporin. These are generally used when in certain population the paroxysmal nocturnal hemoglobinuria PNH occurs in conjunction with the aplastic anemia. In certain types of patients, aplastic anemia can occur concurrently with the PNH, and in those patient population we use the immunosuppressive treatment majorly like the anti-thymocyte globulin or the cyclosporin. Because these patients are prone to the venous thrombosis, it is important to start the anticoagulant prophylaxis in these patients to avoid these thrombotic episodes leading to the formation of Budd-Chiari syndromes and other types of problems. Like these can lead to cerebral veins damage, can lead to cerebrovascular accidents as well. And certain thrombolytic treatments can also be tried in these patients if the thrombus has already been formed. Like the tissue plasminogen activator TPA can be used to break down a thrombus if that is causing a large degree of symptoms. So with that, we complete our discussion of the hemolytic anemias over a course of 2 lectures. We started off by discussing about the inherited hemolytic anemias, and in this extensive lecture, we discussed in detail the various types of acquired hemolytic anemias, what are their causes, what is the underlying pathophysiology, how do we diagnose and treat these types of anemias. I hope you have learned something new from this lecture, and I'm going to see you in another lecture. Thank you for watching sqadia.com.